cruising altitude. So why don't we go ahead and just jump in and get started because we have all kinds of fun stuff to do today. So fairly skinny agenda from my standpoint, but I know Renee has one item and then LJ has invited special guests. So it's just going to be a menagerie of fun today from all corners. As far as the numbers and as they currently stand, we are indeed slowing. We may even be cresting or coming down from the plateau for what was this wave, whether you call it the second, the third, the 54th. It all depends on how you like to look at the graphs. But nonetheless, this too is appearing to pass. From the mortality statistics, as we said, we're still probably right in the thick of it right now. So we may still have another week or so before we really fully see that start to improve and resolve. But hospitalizations are diminishing. We are seeing ICU occupancy diminishing, which is great. The mortality for the Finger Lakes region seems to be being reported in kind of fits and sputters. So we had 0 yesterday. I think we had something like 39 the day before that were reported. Something we'll kind of keep an eye on. But overall, across the region, it does look like we are doing better. Hospital bed availability is, I'd say, flat at the moment. We still have a lot of patients who are awaiting discharge, either awaiting placement or awaiting home care services, whatever the case may be. So the hospitals are still pretty full. I know, for instance, this morning, for years I've gotten the occupancy for Highland. And so, they always run at 100+%. But today they're at 133%, that's pretty high for them. So we're definitely not seeing full abatement of the hospital load at this moment. But as far as new cases, we're definitely seeing a downward trend in that direction compared to the 600, 700 positives a day that we were experiencing not that long ago. So that's all good. As far as other, testing, both facilities and resources are becoming ever more available in the region and across New York State. So as you can see, we've now crested 30 million tests performed. We still have the largest amount of testing per capita of anywhere in the world that I can find reported, quite honestly. So that's good in New York State. We certainly are leading by a pretty good margin in the United States, for sure. Unfortunately, our case rate in New York State, we had fallen to 5th. Illinois had jumped above us to 4th. Not to be outdone, we have once again taken 4th place from Illinois. So New York is back in 4th place as far as most number of cases in the US. As you can see, overall, we're very close to topping 300 million total tested in the United States overall. So probably if we continue at the pace we are currently, sometime probably next week or maybe a couple weeks, we should reach the point where we will have tested effectively every man, woman, and child in the United States very soon, or at least the volume of testing will have accomplished that. I think from a testing standpoint, we're doing pretty well. The concerns right now, as far as case rate, is what the variants will do. The anticipation, although it has not been quite as vigorous as what they had anticipated across the country, there are now at least 4 clinically noted variants that are in circulation around the world. Fortunately, we have really not seen them pass the I guess I'll call it the vertical Mason-Dixon line of kind of the mid portion of the state. So Western and Central New York seem to have been fairly well protected to this point from any of the variants. But we anticipated that by February, March timeline, not only would that become the key reason for infection, but also could spike another surge as those variants seem to be more transmissible. Jumping ahead a little bit, Moderna had released a statement over the weekend saying that they anticipate that their vaccine will be effective against the variants. Pfizer had said the same thing before. However, Moderna is already in consideration of creating a booster for those who receive the Moderna vaccine that would be specifically targeted to the variant variants of the virus that have been discovered to date. So I don't know that that's gone into full production yet, but that has been discussed. So, for everyone who received a Moderna vaccine, there could be another vaccine in your future. Yay, you lucky guys, everybody. So take that for what it's worth. There has also been some discussion in several different venues that the second dose of the Moderna vaccine may have been associated with a bit more side effects or reactivity. I've heard that certainly just colloquially amongst folks, but there's even been some reports that perhaps the second dose of the Pfizer has not been as vigorous a response as what we've seen with Moderna. But again, across the country, the overall rate of adverse reactions has been relatively mundane. There was one report over the weekend of someone dying within hours of their second dose of Moderna vaccine. Very unclear as to the full details of that. That's obviously being investigated very heavily, but it certainly didn't sound like an acute phase anaphylactic type reaction, but I'm sure we'll hear more about that in the days ahead. As far as I know, that's the only real mortality that's come out of vaccination at this point. So more to come on that. From a testing standpoint, we talked before about the two new platforms that were going into effect at the UR. Those are being validated as we speak. The word that we got at the end of last week was that they were coming along very well, and the anticipation is that they should be up and running soon. The plan was going to be by the 1st of February. It sounds like they may even be slightly ahead of schedule on that. So there is no anticipated shortage across the region. So that should not be a problem. We are still not seeing the demand for testing at the rate we were even at the end of last year. So that's good. So testing remains not a problem at the moment. The new pre-procedural testing site is up and running. They are seeing kind of all-time highs as outpatient procedures are returning to normal or potentially even exceeding baseline projections of normal. And they seem to be accommodating that volume very well. So that's good as well. A couple things. So for this week, it is anticipated that the allocation and supply of vaccine to the region will remain low. We talked about last week getting a diminutive amount of the vaccine compared to what we had received in prior weeks. That will hold true for this week as well. In addition, for better or for worse, depending on what you think of it, the state had opted to retain a large quantity, in fact, the majority of the vaccine that had been allocated for use in the state pods. So for us, all of a sudden I'm choking to death. The state pod is in the Henrietta Dome Arena. And so I think it was something like 60, 70% of the vaccine that came to the Finger Lakes region was retained for that pod last week. The anticipation is, again, that the state pods will retain the largest amount of the allocation to the region. There is some discussion that we may see some uptick in vaccine allocation to the state and to the region starting next week. That probably is twofold. Number one, as of today, the anticipation from Governor Cuomo was that New York will have utilized 97% of the vaccine it has received to date. That's very good. By the end of the day, the fear is that New York will have run out of the vaccine that it has received to date. So that's not so good. Despite the fact that New York is doing very well, the U.S. as a whole has only administered about 50% of the vaccine that has been released currently across the country. So one discussion is, will they start reallocating? And then number two, the hope was that production, because we're now going to be about a month into release of Pfizer and Moderna. So the hope was that both were going to be able to up their production within that first 30 days. I haven't heard for sure if that is indeed the case or not. So this week will likely remain fairly skinny as far as vaccine. I know several folks have reached out asking that they've kind of gotten indications that there may be vaccine released to the primary care offices. I know I do need a sip of water. The one time I don't have water. But I have not heard that as of yet. I know we're all kind of hoping and praying that that comes to fruition, so we start to disseminate the vaccine much more effectively. Let's reach to the screen and grab yours and see it. So as far as I know as of yet, I don't have any knowledge or anticipation that primary care offices will be receiving vaccine this week. But again, you guys may hear about that faster than I even do, truthfully. One other piece of maybe good news. So Dr. Fauci last night, I believe it was, made the statement that he believes that the EUA for Johnson & Johnson will be sought and granted likely within the next 2 weeks. Boy, this is bad. So that could be useful for a multitude of reasons. Johnson & Johnson continues to believe that they can upregulate their production to have 100 million doses circulated by the beginning of April. Okay, great. So you still got February to April. That's not terrific, but it's still 100 million additional doses than what we have right now. It also would obviously be much easier to disseminate to practices and the like, as we talked about before. So again, a couple weeks away, that's good news. The potentially best part of Fauci's presentation, which I had not heard before, is that he mentioned that aside from the 2 vaccines that are on the market currently, there are potentially 4 other additional vaccine candidates that are being considered in the United States. So we are aware of the AstraZeneca Oxford and the Johnson & Johnson vaccines. So that would be 2. I don't know what the other 2 candidates are at this moment. Obviously, there are vaccines that have been released elsewhere in the world that were, to my knowledge, not being considered in the US. But it was intriguing that he said there were a total of 6 vaccine candidates currently under consideration in the United States. So maybe that's a good thing coming down the pipe. So more to come. Again, right now we anticipate Johnson & Johnson will be next. AstraZeneca, if we follow what the Operation Warp Speed team said, would not be until April. So it's going to be a little bit of a delayed process between here and there. So that's what I've got. Someone is diligently trying to break into my office as we speak. Oh, I'm getting water delivered. This is the best day ever.
All right.
All you gotta do is choke to death on screen and people bring you water. I'm gonna start having my stomach grumble on screen, see if people bring lunch and everything. This will be a terrific service. Thanks, everybody. Sanofi and Novavax. There you go. Thanks very much, Tim. So with that, I think the only other thing I want to remind people is we have our PPE pickup on Wednesday. A couple things there. I'm a little bit anxious at the moment. So our friend that we know and love at the loading dock, who gives me the stuff that we can bring over here and pack up, he is on quarantine isolation at the moment. So I was supposed to go this morning to pick up my shipment of goodies and could not do that because there was nobody at the loading dock. So hopefully between now and tomorrow morning, he's hoping that he's feeling well, but anticipates his negative test will be back by the end of the day, and then he can be back there tomorrow morning so that we can get it in time to get it all packed up. If not, we have a decent supply, but there's maybe a couple items that we're short on. So I'm hoping we'll have that. Right now, I think the biggest thing that we would be missing out on is medium-sized gloves, which I know are like the most sought after item in America. And then gowns, which are always kind of close to medium-sized gloves, is the most sought after items in America. So those are the 2 things that give me a little bit of stress at the moment, but we will try to get that rectified before we see your smiling faces on Wednesday morning. Otherwise, I think we have pretty much enough of everything else to maintain our supply as we normally are. And with that, I will shut up and I'll pass the ball to Renee, who has an update about vaccine.
Okay, thanks, guys. So many of you, the private practice PCPs in Monroe County received an email from me asking you to send me a list of your active patients who are over the age of 65. As I explained in that email, URMC is reaching out right now to schedule patients for vaccination, age 65 and older. They are reaching out to patients who have been, received a service somewhere in URMC, labs, imaging, specialty care, what have you, within the past 3 years. And the purpose of sending your list to me was to catch that delta of maybe you've got some patients who are, don't get services in URMC in the past 3 years, who are 65 and older, who are still eligible to be vaccinated and who URMC would still want to reach out to. So those calls are going out now for scheduling at clinics. I just want to answer some frequently asked questions that I'm receiving from your practices. Those calls are outbound only. There is no ability for patients to call into URMC to schedule a COVID vaccination. Not possible. If our outbound caller gets voicemail or the phone rings out, no messages are being left. That patient will be put back in the pool and they'll be contacted later. And when I say later, I mean later. I have no sense yet of time frame for when a name would pop back up or the frequency with which calls are being made. As you've heard on the call a million times, vaccine supply is extremely limited, and this is no different. So I just wanted to clarify that there's no messages that'll be left. The person will be popped right back into the pool. Same for folks who are called. They connect with the scheduler. There's a couple of screening questions, and maybe they just had another vaccination for something else a week ago, so they can't receive the COVID vaccination. They're put back in the queue. They're not prioritized. They're not at the top of the list suddenly. They're just back in the queue. So I understand these are the kinds of questions that you are getting from your patients. I understand that. And just, hope we can all be in solidarity together to urge patience and forbearance while we get through this. I will say that one piece of information I'll be sharing with offices on an individual basis is that just as there is no inbound calling for scheduling, it can be hard for a patient to let anyone know that they can't make a scheduled appointment. So I will have some information for you about how that can be, how a patient can communicate it who has a scheduled appointment at URMC, how that can be canceled. Although I urge them to have really good reason for canceling it, because again, they just go back in the queue. They're not on any kind of priority list. So we'll get that information out to those individual practices who submitted lists. Let me know if you have any questions, but that was all I had to share.
I think that brings it to me, Jeff.
All you.
Yes. Okay. All right. So we wanted to take a moment to update all of the pediatric care providers, as well as the adult providers who care for adolescents, about some recent cases at Calisano Children's Hospital with MISC. And so I'll take you back to back in July, when there was an outpatient algorithm that was released. But rather than me talking to you about this, I'm really pleased to introduce to you Dr. Regina Rowe. Dr. Rowe joined the faculty in pediatric infectious disease just about a year ago. But as we were talking a little bit earlier, since she and I had not met, she joined in the year of the lost year where we didn't meet new faculty who came to the institution. So she's going to just review the outpatient algorithm, talk a little bit about some of the cases that have been seen recently, and just give a few tips and pointers for our primary care providers. So Regina, I'll turn it over to you. And when you would like the MISC outpatient algorithm shared, just let us know and we'll put that up for you.
Okay, thank you. Well, nice to meet all 99 people, or 98, I guess, minus one. I'm one, I guess, on the call. Yeah, I just moved here from Texas about a year ago, so I'm new to the northwestern New York area, and maybe I've talked to some of you on the phone that have called in for consults. So hopefully I'll meet all of you at some level someday post COVID. So I thought I would just share just a couple of really quick slides to kind of highlight why we're seeing MIS-C. MIS-C is the post-inflammatory post-COVID syndrome in kids that resembles Kawasaki's. So I'm just going to share this really, and it's just a couple of slides. But I just want to highlight, can everybody see that? Like, did it kind of disappear? Okay.
Try it again, please. I interrupted your share screen with one of my own. I apologize.
Oh, no, it's okay. Half the time it doesn't work. I'm just gonna, I'm gonna try to share my desktop and see if that might be better. Can you see it? Just
Yes.
see my desktop?
Yes.
Okay, so I'll just leave it up like this. So the reason we're seeing it now, we saw it in June, a few cases in June, and we just didn't have very many COVID cases in the Finger Lakes area. So we really didn't see a lot of MIS-C as compared to our colleagues on the East Coast and in the tri-state area and Philly area. So I'm bringing this up. This is actually this was a group that published in New England Journal of Medicine. So this probably would have been one of the July or August publications on describing MIS-C. So MIS-C is multi-system inflammatory syndrome of children is the C. There also are some reports of MIS-A now that we're seeing. So adult providers, you should also be on the alert for kind of this post-COVID inflammatory syndrome. And we're going to pull up the algorithm, so it'll kind of go into some of the clinical presentation, but I just want to explain why we're seeing it in January, why we didn't see it in October and November. And that's because the blue here are acute COVID-19 cases, so diagnoses. And this was, I believe, in the tri-state area back in the late spring, early summer. And you could see the intense peak here in April with the New York City peak and how it gradually trended down in the blue. The red are the MIS-C cases. So our colleagues started seeing these very unusual syndrome like illness in older children that started presenting. And you can see the red here and how the difference between peaks is around 4 to 5 weeks or up to 6 weeks. So if you extrapolate where we are in our kind of major wave that we're going through right now, we're a solid 6 to 8 weeks post kind of when our curves really started going up around Thanksgiving. So it makes sense that now 6 weeks, 4 to 6 weeks post when a kid would get exposed to the virus is when they're going to present. So these kids likely had remote infection. Maybe they didn't even know they were infected, maybe had a close contact, and now they're going to present to your clinic with fever and signs of high levels of kind of systemic inflammation. So just to go, if I can go to the next one, possibly not, that's going to be too complicated. And just to get into kind of the difference, because now we have an overlap of our two curves. We have acute COVID going on, and now we have kids that are far enough past their illness that they could present with fever for a different reason related to COVID. And with the MIS-C patients, we see a lot of GI symptoms. So your acute COVID is going to be more of your rhinorrhea, your cough, your fever, kind of malaise, upper respiratory infection, and they're probably going to get better pretty quickly. Your MIS-C patients are often going to be sicker. They're not going to have your upper respiratory symptoms, and they're going to complain of GI complaints, diarrhea, belly pain, vomiting, nausea, just kind of very non-specific types of symptoms in those. So those are just the two slides I wanted to highlight to kind of reset everyone's kind of clinical appraisal of these patients, because we're kind of in a different phase of our COVID wave. So the resources that you can go to when you're looking, when you're trying to evaluate these patients, we've done our group combined. It's a multidisciplinary group that includes pediatric ID, cardiology, hemonc, and rheumatology have all gotten together and created some inpatient and outpatient guidelines. And we're going to share our guidelines in a second. LJ will share those. But I also want to highlight the American College of Rheumatology, because they've actually published some really good kind of comprehensive guidelines in both long form as well as summary form. Can everybody see the PDFs now, I hope? So you can just Google American College of Rheumatology and MIS-C and find this little short format, which is just 3 pages long. If for some reason you can't find the GCH policy stat, and go through that. Oh, something else is shared. Okay. Yeah. So essentially this follows what we've done with it at GCH and URMC. And when you're seeing these kids, I mean, they will often have a longer duration of more than 3 days. So, it's kind of, your workup should kind of be along the lines of Kawasaki's disease. So they're going to have longer duration of fever. So you can watch a kid for a few days, but as you're getting into day 4, day 5, and you really don't have another explanation, you should really consider Miss C. They're going to have some of these findings that are similar to Kawasaki's. You can see the acute GI symptoms are a little bit different. And then you just go down the algorithm, and most of the initial labs are for acute inflammatory reactants. So you're looking for, it's very similar to a Kawasaki's disease workup. So pretty much if you do your Kawasaki's labs, you're going to get the majority of, you're going to be able to evaluate for Miss C as well. The important thing is a COVID PCR and serology. So LJ and I were talking that now we're kind of in this phase where we're overlapping this acute and post-COVID kind of temporal relationship. So some kids may have had COVID 4 weeks ago and may still be PCR positive. So the key is, are they antibody positive? And that might lean you more towards Miss C. We've had cases of kids that were completely asymptomatic with their acute COVID. And so they did not know they ever had COVID. They had no contact, but they were antibody positive and presented in heart failure and shock. So these kids really can present very ill, and you may not on history have any clue that they were ever exposed. But I think we have enough community transmission that basically every child is at risk for exposure. So just because it hasn't been in the household does not mean the kid didn't get exposure somewhere else or have an asymptomatic case in the household that exposed them. And then if you have questions, I mean, pediatric ID at Golisano's is always on call. I'm sure rheumatology colleagues would be also amenable to taking your calls as well. So if you have questions, you can definitely, phone a friend. So that was about all I had to be brief, but I'm happy to go through the spectrum of cases we've seen or answer more questions.
So Regina, can I ask you a couple of questions? Some things have been coming
Yeah.
in, and then we can open it, then people can unmute and ask questions too. One question that came through is, what's the typical ages that you're seeing at this point? Because there have been a big range.
Yeah, so I think that I feel like the typical ranges we've probably worked some younger kids up for Miss C that maybe didn't have it. There are case reports of going down very young with some of the Miss C findings, but your typical age range is probably going to be on the older end for Kawasaki's, so 5, 6, 7, up to probably more in your teenage range. So the more common age is probably going to be in that preteen to teenager is going to be more common for the presentation. That being said, I did have a kid that was 7 last week. So it can run the full range, but it's not going to be that typical 4-year-old, 3 or 4-year-old that looks like Kawasaki's. They're going to be probably on the older end.
That's really helpful. And I think we've heard from others in the past that, well, some of these kids may look like sepsis, but some of them may look more like even an AHP in presentation. Is that true from your experience?
Yeah, so a couple of kids that we've worked up have definitely gotten abdominal CTs because they had abdominal pain, and then we didn't have any other, source for the fever and the abdominal pain. The CT scan was normal. I would stress that this is a spectrum, is what we're quickly realizing. And every kid doesn't need admission, and every kid doesn't necessarily need treatment. But unfortunately, our labs cannot tell us that. And so I think it's fine to watch a child that's well appearing. And I believe it doesn't really talk about, well, the hemodynamic instability as to whether or not to admit them. I was on with, I talked a lot with my rheumatology colleagues when I was on call a week and a half ago, because it's possible that early intervention with some of these cases may prevent some of the really severe multi-organ dysfunction. So I'll just give one example of a teenager, I believe he was 14, presented several times to various parts of the healthcare system, urgent care and his PCP, a couple of times, had persistent fever with no other localizing signs. The thought was it was a viral illness, and he really just wasn't getting better, started to have shortness of breath, intense fatigue and inability kind of just to do anything, a lot of malaise. He maybe had a rash at some point, but really didn't present with some of these other kind of physical exam findings. He presented with cardiogenic shock. So when he presented to his PCP on the third or fourth presentation to the healthcare system, he was very ill, looked septic, and got referred to the ER for a full sepsis workup. He actually had an aseptic meningitis on his CSF, and he was just in a massive inflammatory state with diffuse myocarditis and cardiogenic shock. As of Friday, he was still on milrinone. They were able to wean it down, but is it possible that if we would have recognized it earlier, could we have intervened earlier and prevented the heart damage? I don't know that that's true, but he had no past history of COVID. He had no contact with COVID. So it was really just a high level of suspicion because he was so ill and everything else was negative, and his COVID antibody was positive. So that's just one example where it's unclear if we intervene early, whether or not it makes a difference in the long run, but just having a high suspicion for the disease, I think will be important for the next probably month or two, because we're going to keep seeing it as long as our numbers in the community are so high.
So I'm going to make sure we open it up to see if there are other questions. I know Mendon Pediatrics posted in here that they noted one issue has been trying to get outpatient labs on a febrile child. And I'm assuming that they mean that, I don't know if Mendon Peds wants to unmute themselves and explain. Are you saying that you can't send a febrile child to the lab to get?
Yes, we have had a couple of them with persistent fevers that we've wanted to get outpatient labs on, but the lab won't see them to draw the labs.
Well, that's interesting. I think we'll have to look into that a little bit, because it would not make a lot of sense for a febrile patient to have to go to the emergency department to get lab work drawn. That would not be a good use of resources.
But outpatient labs, right, they COVID screen everybody that walks in, and one of the questions is fever.
Okay. As a quick problem-solving thing on this, I would think that our colleagues in the 2 pediatric urgent cares would be willing to draw labs on a patient. That would be my first thought. But that is a really good question that I think we need to take up with the labs a little bit more, because we do need to be able to have kids be assessed. And if our providers, I know some people have lab drawing abilities within their offices, but I know that that's not standard for most of the independent practices to be able to do a battery of labs on their patients. So we'll take that up. Thanks for bringing that to our attention. And I think the other thing I did want to mention, because I know this from Brenda Tassini sharing this, there is not a problem now with getting the antibody testing done at all. That is easy for, as long as you can get the blood drawn, that is an easy test to get run at this point, right, Regina? There's no concern.
Sorry, the antibody test?
The antibody test, right.
Yeah, I've had no problem ordering it in my outpatient clinic. Now I don't, I always tell the patients, I don't know, they may get a bill that's different. I don't know with insurance, like how much insurance is reimbursing, but I would figure if you put it as your code, Miss C is coding, I couldn't imagine as your diagnosis, I would be shocked if insurance would reimburse it. But for some of my other stuff, I've fessed up to the parents. I don't know if they'll get a bill for it just because, but I'm not sure about that. But I've had no trouble getting it. They seem to come back in about a day or two.
Okay.
About a day or two. Yeah.
There's a couple of questions in the chat, just that one is.
See them. I saw intervention. I think, well, the first step of the intervention is IVIG. So I would probably say outpatient intervention, there is not any evidence that outpatient intervention is indicated. So I would probably just, if you think they need medication, then they probably need to come to the ER for admission. because it's IVIG and then plus or minus steroids is our algorithm right now. But maybe at some point with the milder cases, we might find out oral prednisone is effective.
Okay. And then there was a question about wondering about taking vitamin D. You know, that there's some discussion that that may help prevent more severe symptoms. Is there enough, there's probably not enough information to even know.
Is that acute COVID? I've seen that kind of mentioned for acute COVID.
Right. I think that, right. I think this question is, would that have any protective value? I think there's just not enough.
Oh, on Miss C.
No. Yeah.
Oh, I don't know that we have enough data. The vitamin D for many things is very, it's been very difficult to conduct good, robust trials for vitamin D across many diseases. So a very good one was actually done for women trying to prevent childhood allergies in their offspring. And it was a very good trial, and unfortunately didn't show an effect, even though everybody thought so. Even the best trials with vitamin D have been difficult to show an effectiveness.
Yeah.
So, but it's generally safe.
Thank you for that.
Mm-hmm.
Are there any other questions that anybody has? Anybody want to unmute themselves if they have a question for Dr. Rowe? And then I just have a couple, just to wrap up things around the return to play status. I'm hearing silence. Regina, thank you so much. There might still be another question or two that pops up in the chat.
Yeah.
So,
kids are being discharged. Many of these kids are being discharged on a steroid taper and wean. So you may see them in your clinic after discharge on a steroid wean, but that's pretty much about it with follow-up with cardiology, et cetera. So that's it.
Okay. Great. Thank you so much for your time and for being willing to join the group today. We really appreciate it. At this point in time now, all of you are seeing these kids post-COVID infection. You're seeing the 5 and ups post-COVID to be able to do the return to exercise clearance or return to play clearance. And so, just really, as you're doing that assessment, in the moment of checking to see if they have symptoms or if they fall into any of the more moderate or high risk buckets that we've talked about, I think it's a really good opportunity to just remind parents that if any of these symptoms do develop over the next month or weeks forward, that they should contact your office directly to be able to have children assessed. I just have to put out one thing. I don't know what the resolution will be on this, but we've talked about the fact that the schools have been unwilling. Many of the schools are unwilling to help with or to conduct the return to play gradual exercise, especially for children just who need it for PE. And so there is a resource tool that I am hoping, had hoped it would be done by now, but I'm hoping it will be done early this week to be able to share out to you all that you could offer to families who have younger kids or who have older kids, even who are not participating in sports, that kind of works them through so the parents are able to work through this algorithm. Some of you have brought to my attention that one of the one of the counties is now requiring a second signature from the PCP, stating that gradual return to play has been completed. We're really trying to get away from that. I think the last thing that families need or that you all need is one more loop in the documentation piece. So we're trying to get this established so the parents can do that return to gradual activity, and then that the schools will then accept that that is complete. But we're working on it. This is one more case we're not having any real standardization, and every district and every county having a little different approach is making this a little bit of a rodeo. So hang in there, let me know where there's discrepancies, and we're trying to bring a little sense and collaboration to the whole process. But I think this highlights, Regina's presentation and reminding us that we're likely to see more of these cases. It is a good thing to have the PCPs have a touch base with their pediatric patients after COVID infection, even just to be able to educate the families around things that they should be careful about. So thank you so much, everybody. Chad, Renee, you got anything else?
There's been a request to share the MISC algorithm, and so we can do that today. That's not a problem.
Yeah, it's been on our site since July, but we'll resend it again. And Regina, if I could maybe get the rheumatology link from you, we'll put that in there too. And then the last thing I just wanted to say is, you know, some of you have been reaching out with unusual cases or interesting cases that have been presented. And I would continue to encourage you to do that. We're going to try to collect some of those. And I do think, you know, if there's enough variability with some of that, we could try to do a session where we just talk about some of these cases and try to learn a little bit from each other so that we continue to be vigilant and educate our staff who are taking phone calls from patients around these issues too.
I think that covers it. The rest of the chat is quiet for right now. All right. If anybody has any other questions, jump in now, or we'll call it a day. Seeing none, and lots of hand wave. All right, guys, have a lovely day. We will see you back on Wednesday. Thanks so much.
Take care, everybody.
Take care.